nice to see you. I know that some people's cameras are off, and that's okay, right? Because we know that you are also really busy people. And this is Eileen Barrett, I should say that. And it's for the people whose cameras are on. It is wonderful to see you. As we start to, some rules that we tend to have is that we do refer to each other by our first names. That if you're able to have your pronouns and your name on your screen, and the reason why we do that, of course, is because it makes it more welcoming to people who are non-binary and otherwise, and also just helps all of us have better communication when we don't misgender each other. And as what we've done in the past to try to build a sense of community and psychological safety so we can feel welcome to challenge each other in the best ways and also to ask questions, say when we don't know things, and learn together, is we do just a little bit of an introduction. So maybe I'll ask people when I call on you if you would say where you're calling from today. And also the question this time is going to be coffee or tea or some other type of morning. What's your favorite morning beverage? Ready? Okay. Because I see her nodding the most at that, Andrea, it's up to you.
I'm pretty sure my coworkers could say this definitively, must be coffee.
Okay. All right. Thanks. Alan, how about you? And where are you from today so everybody knows?
Good morning. Alan Plymouth from Deming. Yes, work 2 days a week still. It's hot in the desert and happy to see you all.
Thanks, Alan. And do you prefer coffee or tea?
I'm a part-time coffee drinker.
Okay. No judgment. We support that. Haley, how about you?
Morning, everyone. Haley Peterson. I'm calling from Albuquerque today. My pronouns are she, her. And I am more of a coffee drinker for sure, but I think I'm slowly starting to come around to tea occasionally for the right moments.
Okay. Thanks. Robert, how about you?
Hi, everyone. I may have missed the prompt, but I think I got it. So my name is Robert or Robbie Sachs. My pronouns are he, him. I am back and forth between Albuquerque and Santa Fe. I'm with the Cannabis Control Division, and I definitely prefer coffee to tea.
Okay, thanks. Hallie, how about you?
Well, until I turned about 55, I never drank either. But a friend offered me a cappuccino when I was in Europe, and I was sold, so I do cappuccino lattes every morning.
Nice, nice. Eleni?
Hi, good morning, everyone. I'm Eleni Bukavalis, she, her pronouns. I'm an emergency physician calling in from Placitas. Coffee, I switched to black tea for a while. It was about a 5-day headache and it didn't stick. Went back to coffee.
Okay. Nice. Well, glad that the headache is gone. That's what's nice. Diego, how about you?
Hey everybody, it's Diego. I'm calling from Santa Fe here in the CMC office. I used to be a big time coffee drinker, but now mostly my go-to morning drink is just water. But if I had to choose, I would pick tea.
Okay, we won't make you choose since you don't want to choose. Kathy?
Hi, good morning, everybody. Kathy Jerry, project manager with the Medical Cannabis Program, calling in from Albuquerque, and definitely coffee. And so I was heartbroken when I arrived to work and sat down and went to take my first sip and realized that it was still in the coffee pot at home. So it's going to be one of those days, but I'm amongst friends now, so that's better.
Yeah, that's rough. That's rough. Yeah, I'm gonna do the from the Hunger Games, Katniss Everdeen with like the the odds be ever in your favor. Let's see. Brenda, have we heard from you?
Good morning, everyone. Brenda Martinez with the Center for Medical Cannabis here in Santa Fe, and I am definitely a coffee drinker. I will say that evening tea is also something that I partake in, particularly a mint tea or a chamomile to kind of wind down at the end of the day. So
Nice.
Both.
Yeah. Nice. Great. Gary, how about you?
I'm Gary French. I'm the medical director here at the Center for Medical Cannabis. Pronouns he, him. Definitely coffee, but definitely with sugar and with cream. I need those two accompaniments to go with my coffee. Otherwise, I'll just default to water. So, thank you.
Okay, thanks. And Rosanna?
Hi, my name is Rosanna Archuleta, and I'm the customer service manager over here at CMC, and I'm calling Santa Fe, and I do prefer coffee to tea.
Okay. And Eden, have we heard from you? I think we haven't yet.
Pronouns she, her. My name's Eden from one of the attorneys with the Cannabis Control Division of the RLD. And it's hard to say, coffee or tea. I used to drink tons and tons of coffee, and I gave that up several years ago. So now I'm just an occasional coffee person, but definitely I think I like that one the best.
Okay, nice. And we might next time have to say what are our favorite places to get them. So just be ready. And I'm Eileen Barrett, and I am in Albuquerque, she, her, hers, and I am drinking Earl Grey, which is what I drink every day. So anyway, so thank you everybody for going with it. I think that we got everybody there, and that when I look to see the attendees and I see Alan twice, I think that is our Alan twice rather than two different Alans. Is that correct? Our Alan from Deming.
I think I have some kind of double vision thing going on this end.
Okay. All right. Well, I'm glad that you're all set, and I'm glad that we've got everybody. So with that, then I know that you already received the agenda. You'll also see that it's been added to the chat, and our first up is the update from the medical cannabis program. And I will mute myself.
Well, actually, I think what we're going to do is go ahead and jump over and let RLD make their presentation. Yeah, I sort of made that switch just so that we could get to that, and then we'll follow them up with the update if that's okay.
Oh, that's forgive me. Thank you very, very much. I'll mute myself.
All right. So again, we'd like to open this time up for our guests from RLD, Robbie and Eden. And we do appreciate you being here today. Our committee members have been very, very intrigued. They have some questions, and hopefully you'll have some answers, but I'm going to turn the time over to you so that we can use this time as much as we can efficiently. So, Robbie and Eden.
Sure. Well, thank you all for having us this morning. As I mentioned, my name is Robbie Sachs. I am the Division Counsel for the Cannabis Control Division. Our task began back in 2021, as I'm sure many of you know, with the passage of the Cannabis Regulation Act, legalizing adult use cannabis in the state of New Mexico. While that legalized adult use cannabis, we also took the responsibility of ensuring that the quality of medical cannabis for qualified patients was maintained throughout the transition. So we have adopted rules regarding quality assurance measures for cannabis products generally, essentially ensuring that both adult use and medical cannabis meet the same quality of cannabis. So to ensure that regardless of whether or not a person purchases cannabis or a cannabis product for adult use or medical purposes, that they're receiving the same product. We drafted those rules in concert with a advisory body that we have called the Cannabis Regulatory Advisory Committee, who essentially is made up of 12 to 15 members, ranging from a medical patient themselves to a cannabis licensee who's a non-voting member. And with the promulgation of these rules, we are about 2 years into actual adult use cannabis sales going forward. Thankfully, we have not seen any sort of effect on the demand for medical cannabis products, at least not to the extent that it would affect someone's ability to access medical cannabis products. There are some legal mechanisms in the Cannabis Regulation Act that give the Cannabis Control Division the power to essentially require new licensees to only serve medical patients, but we haven't had to rely on that power yet because of the robustness of the cannabis market as we've seen it. This last year, we were also able to make our first amendment to the Cannabis Regulation Act since its passage in 2021. That will go into effect actually in a couple of weeks, starting July 1st, 2024. A lot of those changes mostly have to do with our ability to deny licenses, suspend or revoke licenses based on certain criteria. We found that we weren't given as much sort of disciplinary action authority as we would have liked. So we requested those changes. And so we're looking forward to having that power. We brought Eden on as a second attorney within the last month. So Eden will be, spearheading all of our administrative prosecutions. And I don't know yet if I've let you know, Andrea and Gary, but I actually am moving on from the CCD. This is my last week. So Eden will kind of be your go-to attorney for the CCD. So really quickly, at least as it relates to medical patients, we work very closely in concert with the DOH. Andrea, we have meetings pretty frequently. We have to collaborate with, for example, the track and trace software BioTrack, which tracks sales for qualified patients, as well as allows us to kind of track the supply chain of cannabis. And I did see a hand go up, so I'll pause here for other questions. And thank you all for your time.
So while we're waiting to see if others raise their hands, Robbie, this is Eileen. I had best wishes from all of us on your next adventures, and thank you for everything. Yeah, I had a question. I heard you mention about the new amendment going into effect in just a couple of weeks, and the ability to deny, suspend, or revoke licenses. And I want to make sure that I understand that the licenses, of course, are people who are selling. I want to make sure that I understood that okay, and not it doesn't sound like that there is at this time that amendment had any effect or influence on the other part of RLD that also licenses medical providers who certify people to be able to have cards. And I say this because at times there have been some challenges there with some challenges there.
Sure. Yeah, thank you, Eileen, for that question. Yeah, so the power that we're given and will go into effect July 1 is specifically for the licensees that the Cannabis Control Division issues. So those are not the entities that give out can sign off on qualified patient cards, things like that. They're really the licensees who create the cannabis product themselves, who test the cannabis product. Just really quickly, the type of licensees that we have are producers. So they grow the plant, manufacturers turn the plant into a finished packaged product, retailers who sell the product, couriers who deliver it directly to consumers, cannabis testing labs who test the product to ensure there's accurate potency levels, no residual pesticides, residual solvents, other sorts of contaminants. We also have cannabis research labs. We no longer have licensed any of those, but those also fall under our jurisdiction, as well as cannabis consumption lounges. So yeah, these powers only affected those type of licensees, and the other RLD agencies that handle other licenses don't have that same power granted to them through this amendment. It's just those license types. And Andrea, I see your hand up.
Thanks, Robbie. So two things I do want to clarify is, so the way our program is set up is any medical provider licensed to practice in the state of New Mexico that can prescribe medication can do the application. So we don't have a separate approval process for them. So, as long as they are not being sanctioned by their licensing body and are following the regulations, they can just continue to certify for folks. I do want to say, I wish you all the best, Robbie. I think that you took on an insurmountable task, and your calm nature was very important in getting all of this shepherded through. But you will definitely be missed. I will say that. But I do absolutely wish you the best, and I hope our paths cross again. But yeah, so that's how, like, so while RLD licensed medical providers, there is no separate licensure for them to do certifications. So I may have misunderstood, but I thought that that's what you were asking.
In my case, I was just, thank you so much. I was thinking about I guess the intersection of the different dimensions of RLD in that case. And some people may know that separate from this is that I'm also on the medical board, and this hasn't come up terribly often. But so I was just curious. So thank you. And I see Eleni, I'll mute myself.
Thanks, Eileen. And Robbie, thank you so much for coming today. And thank you, Eden, as well. I was wondering if you could speak a little bit more about the testing process. I know we've sort of talked in our group in the past about how there are a few private options and recently a state option. And I was wondering when the testing occurs, if it is occurring sort of at the level of the growers or with the finished product, and if how they choose which lab to test, and if there's any comparison between the labs, if anything has come up with that. I'd be interested to hear more about that.
Sure. As I mentioned earlier, we have a license type specifically for cannabis testing laboratories. And so all cannabis product must be tested prior to being sold to a consumer or qualified patient. The way that our regulations are written, it should require that it happens at the end when the final finished product is actually created. So whether that's an edible or a cartridge or the flower itself, at that point it would be tested. However, we inherited the BioTrack track and trace system from the Department of Health, which had testing at every kind of point. If it moved from a producer to a manufacturer, it had to be tested. Manufacturer to retailer, it had to be tested. And so the product can't move through the system without being tested at each point. So in terms of frequency, it's actually tested more than our regulations actually require, which is helpful in some instances because it catches it earlier rather than, all the labor having gone into actually created the finished product. And then if we find something that would have to be wasted or remediated, so that's kind of the process that we follow right now, and that's on the private side. And so, like I mentioned, we test for the testing labs will first do a visual inspection. So they'll test for any sort of visible contaminants that they could see under a microscope. So pests, dirt, things like that. Then they will test for potency so that the consumer or qualified patient can actually know how much THC content, CBD content, things like that the product will have in it. Then we'll test for the testing lab will test for contaminants. So that will be microbials, and we have a set list of microbials that they'll test for. Pesticides. We also have a set list of pesticides that licensees are approved to use. So we worked in concert with the New Mexico Department of Agriculture to, rather than have a list of pesticides that are banned, to have a list of pesticides that are approved. So that way we know, there are pesticides that come online year after year. There are thousands of them available. We won't really know the long-term effect of them until they're studied in more depth. So the ones that the NMDA are for sure comfortable with are the ones that we allow for, and any sort of pesticide outside of a set action limit would then fail and needs to actually be destroyed. And so then we also test for residual solvents for manufactured products, because when you pull THC out of the plant, sometimes you use a certain sort of chemical process, and we need to make sure that those chemicals are completely removed, at least the ones that could potentially cause harm. So that is the private side of cannabis testing labs, and all of that information needs to be available on the product as well. On the state side, we are working with the Scientific Laboratory Division in the Department of Health to set up a reference lab that previously was working with MCP. And so the SLD has a lot of the equipment, but just in the interim and the transition, we didn't have like a smooth handoff, I think, from MCP to CCD. And so the SLD didn't really keep their instruments validated and things like that. So they're currently in the process of bringing those things online. And we expect that at least potency and pesticides to come on potency, we believe in the next month or two will come online, and then pesticides to come online by the end of the year. So that's going to be really great, I think, for the state from a public health perspective, because we'll have a completely neutral state agency that can take cannabis and cannabis product and, use the incredible staff and instrumentation available at the SLD so we can kind of analyze if there are any sort of contaminants or things like that. So sorry that was a little long-winded, but that is just kind of the scope of cannabis testing in New Mexico.
I popped some of the actual charts that we have within our rules so that if anybody wants to take a look, they're in the chat there, and it lists some of the target compounds for different types of testing that the rules require, as well as action levels. So if anyone's curious about some of the names and numbers, you can take a look there.
Thank you so much. Thank you both.
Of course. I see another hand.
Yeah, thank you, Hallie Faust. I'm up in Santa Fe also. I have two or three questions. First of all, through the RLD, and maybe you don't get involved with this directly, but have there been any medical practitioners who've been sanctioned by somehow violating cannabis regulations in the last 2 years? And my second question has to do with interfacing perhaps with Department of Public Safety, maybe not, but I'm curious how much illegal product, if we know, gets into the licensed stores, and or how much illegal product is a percent of total cannabis available to the population overall. Thank you. I'm going to mute myself because there's somebody, if you hear a moaning in the back, it's not Zobra, it's a guy doing some work in my basement, so my apologies.
Sounds good. So as it relates to your first question, we work closely with boards and commissions, another division of the RLD, and they license medical providers. From what I know, we have not had any instances of someone having their medical license revoked for any sort of misconduct on the qualified patient side. We can follow up and confirm, but we haven't seen any activity on that end. And as it relates to illegal cannabis product, every year we do a demand study. So we have a group called the Cannabis Public Policy Consulting Group that comes in and does a survey and essentially surveys people of New Mexico to see how much they rely on the regulated market versus the illicit market. And year after year, we've seen consumers moving to the regulated market at a very high rate. I believe the last time, and I'll have to double check and confirm these numbers, but the last time it was around 85% of people surveyed were using the regulated market. And so we need to do a little bit more of a deeper dive on the question of how much of the cannabis product that is being sold by regulated licensed entities comes from illicit sources. I will say that from our inspections at the RLD, we do find a few bad actors, and they tend to be doing large amounts, but it's at a single premise site, and we catch on to those pretty quickly. There are a lot of licensees that, they're following the rules. It's extremely difficult to be in the cannabis business because of, the federal prohibition, the way that impacts tax write-offs, the sorts of regulations you can and can't follow. You can't allow it to leave the state. It can't enter from another state. So there are a lot of barriers, and so it makes it difficult for licensees to operate. So the ones who are operating in good faith tend to let us know when the ones who are not operating in good faith are doing so. And so we don't have an exact number, and we are re-engaging the CPPC to do another demand study now that the new fiscal year will be starting next month. And so we'll have more information for you all about certainly the trend line in terms of how many people are relying on the regulated market versus the illicit market. And I think that's a good question that you bring up, and one that we can see if they can kind of dive into to see, if and how we can kind of measure the quantity of illicit cannabis coming from licensed cannabis entities. And I will also say that in this last round of amendments to the Cannabis Regulation Act, we did change the language as it relates to trafficking of cannabis product to make it more clear that whether or not you have a license issued from the Cannabis Control Division, you nonetheless can be charged with trafficking. The way that the previous statutory language read, it seemed to kind of give a blanket pass to anyone who is licensed to engage in activity that would otherwise be considered trafficking. So we clarified that whether you have a license from the CCD or not, if you are growing, selling, distributing cannabis that did not originate in the regulated New Mexico market, you can nonetheless be charged with a trafficking charge, which is criminal. So we do hope that that will also discourage that sort of activity. So hopefully that answered your question.
Yeah, thank you. And from our perspective, all that illegal traffic has not been tested for all the things that you've put up in the chat room. And so we wouldn't know what that exposure is overall, but we'd want to help try to minimize or make suggestions to the legislature to try to minimize that exposure. Thank you very much.
Absolutely. And really quickly on that last point, we have implemented, we have an environmental scientist who started last year, and he's implemented a process where every month he collects lab failures directly from the laboratories and follows up with each of the licensees to see why did they fail, what processes are you doing to remediate or destroy that product. And through that process, we've actually identified some licensees that have cannabis product that's unlabeled. We can't prove that it came from an illicit source, but they lack any sort of evidence to show that it came from a licensed source, and it will fail for something like pesticides. So based on the evidence that we have, we're making, I think, a very safe assumption that it originated from an unlicensed market, certainly grown in unlicensed ways. So we are putting in stopgaps in various different ways to kind of address that problem.
And Haley, just to answer your question, in the 12 years that I've been with the program, I'm only aware of 3 providers who were doing certifications that their license was impacted, but it was not directly related to the medical cannabis program. It was related more to behavior on that provider's part. You know, for example, one of them fired a shotgun at somebody. Another one was accused of using product while he was doing assessments. So there were other issues related to that provider that was not related to the actual certifications themselves.
So there don't seem to be any sort of cannabis mills where, you know, people just
We
run
definitely
through.
We do have those. They're referred to as oftentimes by us as cannabis consultants. That this is what they do. Is they do this for a living of certifying people. We have tried in the past to, when we've had concerning behavior, we do report that to their licensing body. For example, we had 3 providers that did I believe it was somewhere in the neighborhood of 680 certifications over the course of 2 days from the fairgrounds in Albuquerque.
That's productivity.
Yeah, it was very concerning productivity on our part. So we do, when we see that kind of behavior, we do report it to the licensing body. And Gary's done a great job of doing outreach to providers that are certifying. We do monthly meetings with them to educate them about like the process and our program and what our expectations are and what they should be evaluating. So when we added anxiety and as a condition, Gary did a great job of doing education about like how do you diagnose anxiety to make sure that they're not hopefully just pushing people along. And just, you know, Robbie, I'm great to hear that you guys are working with CPPC as well. We've done several surveys with them. So they're getting a very good overview of cannabis use in the state of New Mexico. So it's interesting, and we're actually going to be publishing our 3rd survey with them soon. So
Thank you, Andrew.
You're welcome. I see Eleni has her hand up.
Yeah, thank you. I just had another question. Thank you, Robbie, for that. In terms of packaging and labeling, New Mexico has a lot of really excellent regulations that are designed to protect both the consumers and also inadvertent access by children. And I was curious if you guys are seeing that compliance with those regulations is pretty good. And if there's an issue with any of the maybe unlicensed retailers, I saw a study that unlicensed retailers, this was in California, were much more likely to not be meeting packaging and labeling regulations compared to the licensed retailers.
Certainly. So, I guess to start off with an overview, we do require all packaging to be child-proof and to the extent possible recyclable and compostable. And we also require certain sort of warning labels and information to be on the actual cannabis and cannabis products themselves. So we have a THC warning logo to kind of show that, hey, this product contains THC. There's also information on the packaging to let people know where the product was grown, the test results, who manufactured it, things of that nature. So the consumer is as informed as possible when they're consuming cannabis. As it relates to kind of the branding and marketing, I would say that that tends to be where we see more of our issues in terms of people walking up to the line as to what is appealing to a child. And so having that conversation with licensees about what their packaging, branding, and marketing should look like. And it is a little bit of a difficult I guess, not conversation to have, but it's a difficult standard because there are some sort of subjective things. You know, if you make a wizard who looks like Harry Potter, that would be pretty clear. But then if you make some sort of wizard who is not really, he doesn't look like any wizard, but it's done in a graphic way, you know, but it's kind of more adult themed and, you know, color schemes, things like that. So having those sorts of conversations with licensees about, you know, it's just safer to not have these sort of images, certainly not showing consumption, obviously not putting any sort of parodies of cartoon characters or things like that. That tends to be at least what we see from our licensees, though not I would say, widespread issue. When we do see issues with packaging, that tends to be more of the issue than the actual labels and the child-proof nature of the package themselves. We tend to, just because we have so many licensees, and up until recently, there was only one attorney. So we tended to focus on our licensees and what they were doing. So we do have some knowledge of what's going on in the unregulated, unlicensed market. You know, we get those complaints, and we partner up with the Department of Public Safety and every Thursday we go and at least accompany them to investigate purely illicit, unlicensed instances and complaints that we get. So we do see some of those, and you know, since they're not following our rules and regulations, I mean, they tend to not follow, you know, they don't have warning labels, or if they do, they're not in compliance with, you know, the actual New Mexico state regulations. So there tends to be definitely a lack of compliance on the unlicensed, unregulated side of things, as is kind of expected. You know, they're not following our rules to start off with by having a license. So we do see that, but overall, I would say that our licensees are very compliant in terms of making sure that their products are child-proof. So that's great.
That's great to hear. Thank you.
Hi, so a question related to that, and sorry, it's a bit noisy around me right now, but so for the like compliance checks that you all have done, some of the violations you've seen, are those when you're being asked to like investigate a place, are those mostly coming from consumers where they see products that they think might be in violation or are concerned about product safety? Are they coming from like you said, other dispensaries that are concerned about how a person's operating in another place? And as an additional question to that, do you get any complaints about like worker safety issues, like workers in the production side or manufacturer side?
Sure. So I would say we have a pretty healthy mix of complaints coming from consumers as well as other licensees. Just based on the sheer number of consumers versus licensees, I would say that we get most of our complaints from licensees, from people who have consumed a product that, you know, didn't sit well with them, or they bought it and they opened it up and, you know, there was something on it, or they went inside and didn't like the state of the facility or things like that. So I would say most of them come from consumers, but we do get some licensees who complain as well. one of the problems that we've run into is particularly moving from an unregulated illicit market to a regulated market. There is kind of a built-in culture of not narking on one another. And so we have really actively tried to give people a way in which they can make a complaint. Licensed dispensaries an avenue to feel safe in making those complaints because everything that they submit to us is IPRAble. With the exception, actually, we have it starting July 1st, we have essentially a 30-day window where if we receive a complaint and conduct an investigation, at least for 30 days, those investigations and any materials collected during those investigations are not subject to IPRA, solely because we would, be investigating something, and before we even got back to the office, we would have an IPRA request for all of our findings. And so that just gives us a little bit of a runway to create kind of a legal strategy, an investigatory strategy, a compliance strategy, things like that. And because I think cannabis is such a new industry and we have in our name the Cannabis Control Division, whether it's a worker safety issue, whether it's a tax issue, whether it is a workers' compensation issue, income or wages being withheld, things like that, we get any and all complaints related to anything a cannabis licensee does, whether or not it falls under our authority or not. So what we do is we identify, what potential agency, it could also, sometimes we refer things to MCP because it ends up being a qualified patient issue. But again, because we have Cannabis Control Division in our name, most cannabis related complaints come to us. And then from there, we, funnel them, whether that's TRD or OSHA, environment, ag, Department of Health. And I would say actually most of the complaints that we receive are actually not related to our direct authority. A lot of them, is a local issue. Their municipality is not allowing them to be X distance from a church. And that is entirely up to the local municipality, to establish that. So most of the complaints we get are actually not within our authority. And a lot of them are criminal as well, which we refer to the Department of Public Safety. So that's kind of the spread of complaints that we get.
And just so folks know, I put a link. RLD has done a great job of having an online complaint form, and they've done a really great job of reporting out on inspections performed and violations. So I put a link in the chat for folks to access that. It's good reading. They've done a great job. So
yeah, thank you so much for explaining that. And then one other question I had is, with the number of licenses that have gone out, are all of them like currently active, all 1,000 some dispensaries? And is it possible to get data where it would have like their address or at least their zip code or so? Like, it'd be interesting to be able to like map where all the locations are, if that's something that's possible.
Sure. So what we've done is we've compared our licensing numbers to the numbers and the activity reflected in our seed to sale tracking system, BioTrack, that tracks essentially the supply chain of cannabis products. And from that, we've estimated that about 60% of our licensees are actually active, engaging in cannabis activity. And that is sort of a function of the way in which our licensing system was initially set up, in that we had people attest that they were collecting all of the required kind of local, jurisdiction requirements, certificate of occupancy, business registration, things like that. As of May, so a month and a half ago, of this year, we've changed our licensing system to require that prior to us issuing a CCD license, they actually need to submit to us that they have collected all of the required business registration things that they would need prior to us issuing a license. So we expect that the percentage of actually active licenses will increase. A lot of licensees are actually choosing not to renew, whether that is a function of, it's a new market. There's a lot of stabilizing that still needs to happen. We're only about 2 years in. And so we kind of expected, an equilibrium to kind of find itself in the first 3 to 4 years. And there is also a tool that we have on our website called the CROP, CROP. I believe it stands for Cannabis Reporting Online Portal. And that maps dispensaries specifically that are licensed. And on that portal, you can actually see the number of the sales numbers that they're doing. You can kind of toggle over and do a time lapse to see month over month what they're doing. And we update that once every month using BioTrack data. So we did that really because we were getting a lot of IPA requests related to activity happening and who was in what zip code and things like that. So I can get that URL pulled up really quickly and put that in the chat. But that's a good tool to at least poke around for dispensaries. It doesn't show all of our license types. It doesn't have manufacturers, producers, testing labs, things like that. But there tends to be a lot of focus on our retailers and dispensaries. And so that's a good tool for that.
So this is I keep on getting kicked out of the meeting, I think because of bandwidth. I don't even know if you can hear me. I don't see additional hands that are raised. Okay, thank you. I'm not saying, I shouldn't say I keep getting kicked out. That sounds very aggressive. I keep on losing the connection and then reconnecting. There's a tremendous amount of information that is just shared here. And of course, my goodness, the work that has gone into all of this is remarkable. You know, it like distills down to a 20 word hours and hours of work. I'm going to pause here to see if there's any other questions. No. Okay, I don't see.
Eileen, I was just
Please.
Just one more quick question, if we have a second. Robbie and Ian, thank you both so much. This has been really, really valuable. I'm wondering if there were an area that you think needed further resources or something that you would want to focus on or that you think would be really valuable for legislators to kind of be thinking about. Is there any one thing or any area that you would bring up, I guess, as a final question?
Sure. So I would say there are kind of two that we have visited over the last few years that haven't made it quite over the finish line yet. But boosting law enforcement authority for the RLD specifically, so that we can kind of investigate our own unlicensed activity in a more direct way. There are a lot of priorities, obviously, that DPS and local law enforcement agencies have to be focused on. That violent crime, other substances that are more addictive and cause a lot of really adverse public health outcomes tend to be the things that they focus on. And so allowing us to kind of have our own internal ability to investigate, prosecute these cases for the really, really egregious unlicensed entities that we're seeing. That's something that we would like to see, both in terms of authority and then also funding. One thing that we learned from bringing the Cannabis Control Division online is, for such a large undertaking, there does need to be an equivalent amount of funding associated with that. We were able to do it, but I think we could have even done a much better job with adequate resources. And the other thing that we're kind of trying to solve for, as well as other states are trying to solve for, is intoxicating hemp products and how that will affect the regulated cannabis market. The way that the Cannabis Regulation Act defines cannabis is by delta 9, so delta tetrahydrocannabinol 9. And when you take a hemp product, you can manipulate it chemically to create a delta 10 or a delta 8 that completely falls outside of our regulatory authority. It doesn't fit squarely within hemp. And hemp isn't really, hemp rules are not really created to address any sort of intoxicating products and things like that. So we're seeing a lot of states have these products that are sold at gas stations that seem to have the same sort of intoxicating properties as Delta 9 cannabis, but are not regulated because they fall outside of the regulatory scheme. And so thinking about ways to address that, and we don't know what these products will do in the long term, because they're synthesized, they're derived unnaturally. We don't really know the long-term health outcomes. So that's something that we're concerned about and keeping an eye out, as well as other states are. So I would say those two things are kind of our goals that we've focused on in the past and will continue to do so.
That's really valuable. Thank you.
This is Eileen. Yeah, that was tremendously valuable and a wonderful question and expertly answered. Thank you. Team, what other questions do we have for Robbie or for Eden? Okay, I did my requisite. I forgot to say that in the rules for the meeting, that when I ask a question that I would pause, I would count to 7 seconds to give people time to unmute themselves or time to raise their hands. And I didn't see that anybody had raised their hand. So I think that, again, I just wish to say, just again, our gratitude. This was tremendous, tremendous work. And thank you, thank you. And I hope that everybody has seen that there's a lot of URLs in the chat that I think will be continued resources for us. So team, with that, and then thinking also about and actually before Robbie goes, I'm gonna ask if everybody can unmute yourself and clap and say thank you. All right, and count of 3, everybody unmute yourself. I can totally see that you're muted. Okay, thank you. Okay.
Yay. And all the
Thank
best to
you.
you, Robbie. You will definitely be missed. And Eden, I look forward to working with you. But yeah, I don't think it's fair that you're leaving. I just want to point that out, but whatever.
Thank you all. It's been a pleasure working with you all, and thanks for the time. I really appreciate it.
Thank you, guys.
Thank you. And thank you, Eden. So Gary, thinking for the agenda as we move things around, what would you recommend that we go to next?
Why don't we go ahead and do the update from the medical cannabis program of the CMC, and Robbie and Eden, you're welcome to stay or depart. If you want to, listen on in, that's great as well. But yeah, Diego and I will go ahead and do the update. We'll sort of truncate it a little bit so that we have a little bit more time to delve into the timeline. We wanted to revisit that as well, to make sure that we're keeping up to date with our projected completion dates. And then I think the child access group really has made some substantial progress, and we'll probably take a look at what they have already prepared and take a peek at that, because yeah, they've done a great job with that. So if that's okay with you, Eileen. Oh, one thing I was going to recommend is, if there are other questions that we might have for Eden or Robbie, we can save those and then we can share those with them, and hopefully get, if there's follow-up questions that just evade us at this point, we can ask them at a later time and hopefully get some answers. I think they're still with us here, so yeah, I'm sure they'll answer those for us if we do have some of those. And that being said, Diego.
Okay, thank you, Gary. I'll go ahead and share my screen real quick, and I'm going to give everybody a update on our current enrollment numbers. Right now, and these numbers were taken on the last day of last month, so they're relatively current. So right now, our current enrollment is at 79,793, and that is a significant decrease in enrollment from last year, which was about 100,000. But if we look at month to month decrease in enrollment, that number is only 393 from last month. And if you look across the timeline of the year, that's one of the smallest numbers of decrease in enrollment over the year. So that's actually a positive number. Next, we're going to look at the 3 most commonly enrolled qualifying conditions for the program. Number 1 is still post-traumatic stress disorder. Number 2 being severe chronic pain. And number 3 is cancer. And you can see post-traumatic stress dominates with about 40,000. And if we look at the percentage-wise, over 50% of all patients enrolled in the program qualify with post-traumatic stress, with almost 51%. Now, if we look at the number of individuals enrolled by age, right now it's kind of neck and neck for our most popular demographics, being between 31 and 40 at about 15,000, and 61 to 70, almost dead even with the same, about 15,000. And if you look at the percentages, those two demographics, again, dominate at right about 19%. So if there's not any questions, I'll let everyone know that we do post those numbers every month on our website. So if there's anything that got missed, we do have those on our website.
All right, and I'll start sharing my screen. Okay. And again, this is sort of a follow-up with regards to the rescheduling of medical cannabis, or of cannabis rather. And initially we presented this a couple months ago. It was for I think the Medical Cannabis Advisory Board, and then we had a cannabis forum. But there have been some updates since we first shared these slides, and I don't think I've shared this information at all with the Public Health and Safety Advisory Committee. But I do think that this is something we're going to be hearing a lot about as it progresses. So let's just give a little bit of background. Again, back on August 29th of 2023, the Department of Health and Human Services recommended that the DEA the reschedule cannabis from a Schedule I substance to a Schedule III. And so if we look at what currently has been in Schedule I, we see heroin, LSD, MDMA, peyote, things that typically can be very addictive. And then the goal would be, or the plan here would be, to reschedule cannabis and schedule it under a Schedule III with substances like ketamine, Tylenol with codeine, antibiotic steroids. So again, Schedule III substances have an actual accepted medical use and then maybe lawfully dispensed by prescription.
Jerry, did you say you were sharing your screen? I'm
Oh,
not
is it
seeing
not
it.
showing? Okay, let me go back.
There we go.
There we go.
Okay, I see the presentation.
Great. Yeah, it didn't pick it up. So here we go. So again, here's the background. So back in 2023, HHS made this recommendation. And then upon scheduling a substance from Schedule I to Schedule III, one would have to recognize then that it does have some medical use. And so this rescheduling would recognize that cannabis does have some medical purpose. It also acknowledged that cannabis is less potential for abuse than some of those other substances. And currently 38 states, 3 territories, and the District of Columbia allow for medical cannabis use. And then 24 states, 2 territories, DC, allow for adult recreational use. So again, if it is rescheduled, there would be a lot of implications, and those implications fall not only at the federal level, but at the state level, and also the patient level as well. So with regards to federal implications, rescheduling would not make all medical or recreational cannabis products legal at a federal level. Okay, so products such as flower and edibles, vape products, suppositories, topicals would all still be illegal until FDA approved. And so that remains a big question. What will the FDA, what type of bite would they take out of this? What will they seek to approve, given that we have so many products already out there? Production and sales. Those who manufacture and distribute, dispense, and possess medical cannabis may now be able to do so lawfully under the CSA. And so producers and retailers would be able to deduct those costs of selling their product for the purpose of federal income tax filing. And then they would also gain easier access to banking services for cannabis businesses. So this perhaps is where the rescheduling would really have a huge impact, is actually for those producers and retailers. So one question too would be, well, if it is now sort of legal, if it's a Schedule III, will we see the VA patients or the Indian Health Service patients, would they now have access to providers who would be willing to certify them or could certify them for the medical cannabis program? I think one of the other large impacts would be on research, because with the less strict regulatory control as a Schedule III, this would likely promote greater research. More people would want to take a bite of the apple and try to study this, but also they'd likely have access to more appropriate product to study as well. And then one question is, will improved access maybe cause pharmaceutical companies to pursue the development of additional cannabis drugs that would pass FDA muster. So again, I think a big question is, what will the FDA, what will they test? What will they approve? And then here's a question, would FDA approved cannabis products be sold at pharmacies then? So very interesting. And then state implications, you know, again, the horse is already sort of out of the barn, and I really just am not so sure, you know, if this goes into effect, would the FDA try to pull back some of the products that are out there? Because again, there really is this conflict between state and federal laws as it currently is. Will the FDA fully enforce regulations on cannabis products as it does for other Schedule III drugs? So again, you know, this would require the FDA to do a lot of testing and sort of play catch up here. Will they just carve out cannabis products that are currently in the market and maybe just allow those to continue moving along and being sold? Or would they try to claw it back? Or would they start requiring a prescription for things? Again, patients that participate in the medical cannabis program now, they're certified to have a condition that may benefit from the use of medical cannabis. Would a Schedule III substance, would that then require a prescription? And what would the FDA demand of providers? Again, that's something that is yet to be determined, but could be very interesting. And so patient implications. So those who use medical cannabis lawfully may benefit in the following ways. They could have improved access to public housing, obtain immigrant and non-immigrant visas, purchase and possess firearms. That's an interesting one. That one I would still believe, because it is an intoxicating substance, probably would still be, you know, problematic. But again, what would be the impact there? Again, federal employees would face fewer barriers to employment. And then, you know, the military, that's a question, you know, would somebody be able to utilize cannabis and then be in the military? What would their ready status be? What would their safety sensitive status be? And then again, with it being rescheduled from a 1 to a 3, federal cannabis crimes or penalties are diminished or reduced. And then again, we talked a little bit about this, about the providers, you know, would they be required to prescribe? Would you have to actually write an actual prescription with a specific dose and administration details, as we do for other Schedule III substances? Will the insurance industry start compensating providers for the time and energy spent evaluating and educating patients about medical cannabis if it is a Schedule III substance? So again, it even has implications for providers. And so next ups, and again, these asterisks here are things that have just updated since we had our Medical Cannabis Advisory Board meeting. So number one, the proposal to reschedule from 1 to 3 was reviewed by the White House Office of Management and Budget, and it was moved forward. And so on May 16th, a notice of proposed rulemaking was submitted to the Federal Registrar by the Attorney General, which initiates the formal rulemaking process. And upon doing so, that opened up the public comment period, which we are now in. The public comment period does end on July 22nd, 2024. That link down at the bottom will take you there if you want to leave a public comment for the federal entity that is doing the rulemaking. But again, that question period is now open. And so next steps would be, after that rulemaking and those comments are done, there'd be a review from an administrative judge. Probably some litigation would be involved there too. And so we're actually, you know, maybe looking at something, and I think this timeline might be reduced a little bit, probably maybe something from, well, I would stick with maybe 12 to 18 months, maybe 9 to 18 months. And there's 2 examples here of how, you know, it just really depends. Hydrocodone-containing products took 9 years to be rescheduled, but then Epidiolex, it only took 3 months to get it rescheduled. So the time length that rescheduling can take place is really a crapshoot there. It can take a long time or a short time, depending on you know, what type of rule bending one wants to do. So, and again, we'll move on from there. I'll stop sharing my screen and Actually, I will go to here. Our okay, am I still sharing?
Yes.
You are, yes, it's an Excel file.
Okay. Yes, I had to drag it over here. So again,
Ellie has his
here.
hand up.
Oh,
Just,
okay.
sorry, just in case you had a question about some of the last stuff.
Any questions? All right.
Can you enlarge that some, Gary?
Yeah. Is that better?
Maybe a little more, thanks. Okay.
So again, on our SharePoint site, we do have the timeline with regards to what some of our goals are with regards to getting some of these items completed. And so our first team, the Child Access team, has been making some great progress. And by the way, Crystal is unable to attend. She did email me. She is in and out of service. I believe she's traveling, and so she does apologize for not being here, but she did definitely make the effort for that. And that being said, you know, we had a due date here sort of 6/28 for some document content to be prepared and ready to submit for review by Hallie and by Eileen. And so we're doing great there. And some of the other groups, you know, we're looking at early July there, July 19th. And so we're sort of right in the middle of, you know, summer travel time getting to some of these deadlines here. But I do think that with the recent data sets that have been shared with us from Haley, that, you know, we have some of these, you know, really pretty much answered, especially the poison control, I think is going to be very adaptable from what Haley has shared. But back to here, I'm just going to, you know, open up the child access here. And one thing we've done for each group is that, you know, we had that brainstorming section when Libby was still here. And so we sort of split that out from the written document because again, some of those references, some of those graphs and charts, you know, a lot of that is excessive at this point. And so I just want to click on the Word document here that Eleni and Crystal have been working on. And I'm actually maybe going to hand this off to you, Eleni, if you want to share a little bit about where you all are with regards to next steps and so forth, if that would be okay. And I'll just leave that.
Absolutely.
I'll just keep sharing if that's okay. And if you want me to scroll down or up, just tell me what to do.
Yeah, thank you. So we decided to split child access into 3 groups, and I can't remember what we've presented to the larger group or not. But basically, we were going to do 3 categories. We were sort of thinking about it in terms of child access and exposure, because really, when you're talking about a 15-year-old and a 2-year-old, and versus, you know, a fetus, those are all very different categories of individuals. Hallie, was your hand up from before, or
Yeah, I had a couple questions from the prior presentation, just real quickly, but we can take
let's
them
do that
later if
first.
you want. There no. I guess my first was how did you know when this all started between recreational and medical, the thought was there wouldn't be much of a reduction, but there has been, you know, substantial reduction. How does this compare to other states? Do we have any idea? Did they see similar changes in medical versus recreational?
I can go ahead and answer that. Yeah, actually, the other states showed a much more dramatic decline. Arizona, and I had some previous slides on that, and I can maybe bring those next time. But Arizona and Colorado had huge declines in the first couple of years, and then gradually clawed back numbers over duration of time. And I still don't think they've quite reached the level that they had prior. I think that we actually have more participating patients in our program than Colorado does right now, and I haven't looked at Arizona lately. We never had quite such a precipitous drop. We did have a drop, but it was not the huge amount that we saw in those other states. And we actually have held pretty steady since then. The decline has diminished and plateaued. So it was not necessarily a surprise that numbers went down. And we are looking at factors that might explain why the numbers haven't rebounded even more quickly. But we've done a great job here in New Mexico in maintaining our patient population and maintaining that instruction that they get by seeing their provider. So yeah, less precipitous drop. And I think we're probably going to see those numbers transition and hopefully start going up here in the next future as well.
I wonder if there were differences in incentives, for example, taxation or other things that from those states versus ours.
Could be. Again, I guess depending on the benefit of the program and the ease of accessing the card, or even the costs incurred. Like California, I think is quite costly to get a card. Again, here in the state of New Mexico, the medical cannabis card is free. And I think that that barrier has been reduced so that patients can, if they do see their provider and it's part of their routine follow-up, they can sometimes get their card renewed and it's free for them. And so that barrier, I think, is reduced here. And that's one reason why I do think we have a lot of patients returning and coming back. They also are getting instruction from their providers. And one thing I want to point out on that slide from Diego with regards to the age groups, that, I think it was the 70-year-old age block. Those are patients that really do prefer having the counsel of their medical provider guiding them through this. And I don't think that they're going to just, stop accessing the medical cannabis program. I think they having their medical cannabis card gives them legitimacy, and it shows that they are using it for strictly medical uses. And so I think that because we do have a lot of patients in that age group, that's one other reason why we do continue to have large numbers of people in the program.
Thank you. My second, this should be a quicker question, but one of the other items that might be under patient implications is then insurance coverage of cannabis products. And you mentioned insurance and the provider implications, but it would be interesting to see how that happens because, it's granted they're third-party insurance providers now for drugs and their benefits aren't necessarily strictly FDA approved, therefore you get to use them. But I wonder how it may be impacted once the schedule is changed.
Well, that's going to be, again, a question for those insurance providers, with regards to what they choose to follow. But again, I do think that it is a watershed moment in the rescheduling for that question. I mean, I can see right now as a Schedule 1 how insurers are going to, maybe be able to not necessarily compensate for a Schedule 1 substance. And it will be very interesting. Will insurers simply compensate for what is FDA approved? Or will they compensate for anything that's out there cannabis product wise? And I think that, given that insurers aren't necessarily, well, let's just say I wonder if they would constrain their reimbursements to just only what's FDA approved. And so that could be very limiting with regards to that. And again, time's going to tell. And there was that one slide there where it says lots of litigation. Yeah, there'll be those questions I'm sure will be ironed out, but it is an interesting question, and we'll see how that could impact patients. That also could be a driver of more patients into the program if insurers start compensating for cannabis products as well as for the evaluations.
And Hale, just so you know, with our the survey that we're going to be releasing soon, we do ask, the survey did include questions about, do people plan on staying in the medical cannabis program? What do they find beneficial about it? How many of them were able to go through their primary care provider to get their medical certification done? How many of them had to seek a cannabis consultant or outside to get that done? So we do know that is a barrier for a lot of folks of being able to get that medical certification done by their primary provider. So we're trying to do a lot of work of educating providers about, like, they're not going to come and pull your license if you do this. So.
Yeah, and I think we also have asked a little bit about their insurance status as well. I'll have to revisit that in case we did, because Hallie, you actually, I think in our previous meeting, talking about, access and why, are people just accessing cannabis because they don't have insurance and it's just easier to access cannabis than it is to go through, an insurance company and use typical Western medicines. And so hopefully we'll have that additional information. And again, thank you for prompting that thought for us. We did try to include that in that CPPC survey.
Eileen makes the comment that it'll differ by payer, and that's absolutely correct. And of course, all those corporations that are self-insured, and a great many of them are, and that may be true in New Mexico. I don't know what the percentage of self-insured companies or county health departments, or sorry, county departments, or local, there's the city of Santa Fe self-insured for health insurance. I don't know, but those will all make their own decisions in some ways, and there will be political pressures also associated with that. So thank you.
Sure. All right. Back to you, Eleni.
Sure. So yeah, we split this into 3 parts, sort of talking about exposure during pregnancy and in the early postpartum period via breast milk. The younger pediatric patients under 12, which are more likely to be sort of an accidental poisoning, unintentional exposure, and then adolescent and youth use and exposure. So each section has and Gary, you can scroll down if you want, but each section has sort of an introduction with what we felt were kind of the relevant materials, followed by figures and data presentation. So the first section is on pregnancy exposure, and this is the PRAMS data. And Haley, thank you for the updated PRAMS data. I was working on including that last night. You can see that, so this is pregnant people reporting cannabis use in the month prior to pregnancy. And you can see sort of that steady increase over the last several years. It's kind of holding steady between 2020 and 2021. It's also, all of this, it's difficult to tell how COVID is impacting this. And I feel like that's worth mentioning in the report at large somewhere. I'm not sure where. I haven't mentioned it in this body of text here. So that's something for us to consider. So then if you scroll down, I actually incorporated a couple more of those PRAMS data sets. Just, I thought it was interesting that there seems to be a larger percentage reporting cannabis use in the month prior to pregnancy in the under 25 age group. And then in figure 3, if you keep scrolling down, and obviously this needs to be like formatted, but it's also interesting that areas with a rural designation seem to have a slightly higher report of cannabis use in the month prior to pregnancy. And so that could indicate that those are possibly more at-risk populations, younger pregnant people and pregnant people in areas with rural designations. And so then moving into the younger pediatric groups, unintentional exposures in children, a lot of the literature from other states has shown an increase in ED visits, hospitalizations, poison center calls in young children with commercial legalization, particularly surrounding edibles, and New Mexico's data really reflects that. You can see these are poison center calls increasing for all age groups, most remarkably for that 0 to 5 age group. And then if you scroll down some more, you can also see that by and large, especially for 0 to 5 and 6 to 12, which are probably the more accidental exposures, as opposed to, the adolescents and teenagers, that edibles are the culprit there. And this is again poison center calls. So just scrolling down a little more, this shows kind of it's a pie chart of the different products. Haley, I'm probably butchering this explanation of your data. Thank you for making such beautiful charts. Haley did all of these, and they're very compelling. Thank you. But you can see that in 0 to 5, and then even if you scroll down, even more pronounced in the 6 to 12 age group, it's really edibles that are driving these poison center calls, which reflects what other states have found. And then I incorporated some of the data. Thank you, Haley, for making that. So you can sort of see the age groups over time, both for the ED data and the hospitalization data. specifically in Colorado, they found many more ED visits, hospitalizations, and also more severe presentations requiring more inpatient stays and more ICU stays for pediatric patients following commercial legalization. My read of our data in New Mexico is interesting. Overall, it seems like they've held relatively steady, particularly as a function. And Haley, please jump in if I'm misinterpreting this. But it seems like it's held pretty steady as sort of a percentage of visits overall. Volumes of hospitalizations and ED visits have in general gone up since COVID. Anecdotally, anybody working in a hospital would say that as well. Have noticed that, but it's also reflected in Haley's data. And so overall, if you keep scrolling down the charts for both, the top one was EDs, and then this is the bottom. This is hospitalizations. I chose to include the figures where it's the ED visits and hospitalizations as a percent of total as opposed to an absolute value. They seem to hold steady as sort of the proportion of total visits. It's interesting to note that even though the charts look like they're holding steady, if you look at the absolute numbers, particularly in the 0 to 5 age group, the absolute numbers are extremely small compared to like the overall N, but both ED visits and hospitalizations for the 0 to 5 age group for cannabis related issues have at least doubled. So that I think it's in the body of text somewhere up, but I think there were like, 6 ED visits for cannabis related issues in like 2019, and then 19 or something. I'm saying these numbers wrong. Yeah, it's in the middle of that second paragraph right there. So there were 25 ED visits in 2019 for cannabis related issues, and then 50 in 2023 for the 0 to 5 age group, and then 6 children 0 to 5 were hospitalized for a cannabis related issue in 2018 and 17 in 2022. And so these absolute numbers are very, very small, both compared to like cannabis related issues in the population in general, and also in terms of hospitalizations for children. I don't know if that's meaningful or not. And so that's, I would be interested, Hallie and Eileen, when you read this, and I know that I'm sure you're taking a look at the data that Haley sent as well, if I'm reporting this in a way that that you agree with that in terms of accurately reporting the data. And Haley, I'd be interested to see what your takeaways were from looking at that data as well, with you working with the data. And then the final section is on youth and adolescent risk, and this is Crystal's section. And I think that she's going to incorporate, I think we still need to, I'm not sure if these are the updated figures yet or not. I apologize. I haven't had a chance to talk to her before this meeting. So that is where we're at with this. I think we were just, I was working on just kind of tightening up the text a little bit. And then I think the next step is to really see what you guys think when you read through the draft, if it's sort of the length and amount of information that we were thinking, if it's sort of written at the appropriate level that we were thinking, and if sort of what you think about how we're sort of reading and interpreting the data.
And let me, like this graph right here, what if we took out the 18 to 20 and the 13 to 17-year-olds and then, just showed, you'd get maybe that more dramatic, that doubling would be more visible, I'd assume. But again, perhaps it's good to have all those groups there.
It's actually more visible on the other set of charts where it's the absolute numbers as opposed to the percentage of total. And it's still, they're still like, yes, they're still very small when you're including the older age groups too. It would be, you're correct, it would be more dramatic if we took out the older age groups and then if we looked at the absolute numbers as well. I do think that's interesting to note, even though the absolute numbers are very small. Hallie and Eileen, you both have your hands up, I see.
So I have 3 quick questions. First of all, this is great, and I read this the other day and was really happy to see that we're making progress on this kind of thing. 3 questions about the overall product. One is, first of all, it would be useful to know if the population stayed stable, because then we wouldn't have to give rates. But if there was any significant jump in any part of the population that we ought to be aware of, rates are always better than numbers or percentages. And so if possible, we could, at the very beginning of the report, say that the population stayed stable, then all these graphs and charts are perfectly fine the way they are. If there have been some major changes, then we ought to know that. I guess related to that, secondarily, is and I'm not sure how to do this, not being a biostatistician, but if there are any ways to note where there are some what appear to be significant jumps, can we state that they're statistically significant? I'm, given the data, I don't know how well or how easy it would be to try to draw a statistical conclusion as opposed to what appears to be a concerning conclusion. From 25 to 50, for example, as you said, we don't know how significant that is given the population size. And then the only other thing I would ask is on the overall report, some of the data are to 2021, and I understand that's probably all we can do for now. Are they relevant to, because that's before recreational came into place, are they truly relevant to this discussion for this report, or should we wait until we have, say, next year's report? Because I think this is supposed to be annual, right? If I read the regulations right. Should we include the data where we have differences from, say, 21 to 23, or even if we don't have differences, but to show those trend points versus just going up to 21? And I throw that out for the group to discuss because and especially the folks from DOH, because I'm not sure what you think the legislature might want in that regard. But Elena, I really, it's a terrific beginning for this report, and I appreciate that. I don't know if you noticed, I threw a few little things in this minor point. Do we want to include references? Or do we for ourselves include references, but take them out of the report once submitted because it's too much information for the legislators?
Yeah, we had a discussion about that when we started writing, and I've actually drafted it with references and took them out in the body so that it was less wordy, but could certainly add them back in if the group would like to do that and feel that would be valuable for them to see. Or if we can just say to them, like, hey, if you're interested in where, what studies, what literature this information is coming from, we can get that to people if they need to.
Or we could have the report. It's one document, and then the report with references is another one that comes out for those who want more detail, I guess. Yeah. But I leave that to the guidance from the DOH because they've done more of these kinds of things and understand the politicians perhaps better than I do related to these laws.
They want the references. I could tell you that. Yeah.
They do. Okay.
Yeah.
Okay.
Lenny, this is Eileen. This is really wonderful and remarkable work. And I wonder for the team that if we think about that, in the spirit of that, the legislators might want the references, they're pretty unlikely to check them. And most will have general statistical innumeracy because most people in the world do, right? So why would they be different? And that's also, so I think when I think about the spirit of begin with the end in mind and what are we hoping to get out of the work, what I love about what you've done is that I think that there's so much rich information here. And I wonder if I might also ask that if we consider that we had this really rich conversation, I think our last meeting, about thinking that what can be the intersection of what is big enough to matter and small enough to win, or what is achievable and actionable. And what I love is that there's some really actionable conclusions from here. So what I would ask people of, what do we think about a frame, is that our frame is building the case for, I believe that what we had talked about last time was reducing childhood access. So some of that was about things like maybe it would be having lockboxes available. And then also, I think that lockboxes are probably the thing that could get across the finish line with the legislature. And I already did hear about a bill that is being sort of developed related to that. Another one would be having an epidemiologist and also a dashboard and the ability to maintain it. I think were three things that we had talked about trying to, that were sort of evidence informed and that we are building the case for. So I wonder about maybe a couple things. One of them is that our framing will be always building the case for those things. And then we have this wonderful opportunity, to me, it seems to be, to say, we have a brief report, but on our, that's for the legislature, but that we have more, say, resources and references that are available on our website that we can provide on request, so that we can sort of focus on getting across the finish line. The a couple of forgive me, I said those three things, but I also felt like what we heard from Robbie, and that it looked as though Eden was nodding her head in support of, was maybe some recommendations about, which we'd have to see what happens with but what are their recommendations about boosting law enforcement capacity of RLD? And then also, what is a consideration about hemp intoxicating products? I think that the latter particularly might be a little bit harder, since that's really emerging right now, and that wasn't solidly under our statute, or what we were under our statute. But maybe I'm getting really rambly here. But maybe I'll ask the team, I'll ask everybody here to think about those things as our framing, which is, as much as possible, we're making the case for the things that we're hoping to get done from the legislature. And I think that the work that you've done really supports that. And I want to thank you and congratulate you. So maybe I'll pause there, because I got really rambly there, because I'm hungry. Sorry.
No, thank you, Eileen. I think that's really valuable. And I would add to, I agree with the framing, and something that I've been considering while I've been doing a lot of the reading about the child access and the consumer and product safety is something that Robbie brought up in terms of the packaging, and that we've commented on repeatedly, as to how appealing to children the edible packaging looks. And Haley's mentioned this, there are states and countries with more clear-cut guidelines. For instance, in Canada, I believe the packaging has to be white. There are sizing restrictions on warning labels. There are some things that could potentially make that line that Robbie was talking about, that come right up to, in terms of the packaging looking appealing to children, maybe be a little bit more clear-cut. That might be a potential achievable option. I also, there is emerging discussion in the literature about concern for Delta-8 products, and some very adverse presentations and pediatric poisonings related to them. And it may be worth at least a mention, even if we don't have any data yet, if the group agrees that's something that might fit under consumer and product safety potentially as well.
Lenny, this is Eileen. I think that your framing there about the other hemp intoxicating products, I think, is a really important thing to get in people's radar. I also, of course, love the packaging part for child access. That's probably a pretty heavy lift, because that's, and to some extent, some retailers, that's what they're depending on, right? Is that. So, but as scientists, I think that your framing there is perfect. Thank you.
The other thing I thought I might just explain a little bit about some of the data with the rates, because the rates that we're showing, Eleni explained it well, they're essentially making it a proportion of total visits. And part of the reason why we use total visits as the denominator is because the data I'm giving, so the numbers are not necessarily, it's not necessarily that 6 children were seen in the ED, but there were 6 visits. So for all I know, it could be the same child. I hope it's not, but it's visits, not necessarily people. So sometimes using the population-based rate, even though some people will do that, I find can be a little bit inaccurate if it is potentially the same person going multiple times within a time period. And also the total visits, using that as an indicator, especially for our ED visit data, account for things like when there's an outage in a hospital reporting into the facility. So if we're missing some data for a short period of time, it would account for those in both the numerator and the denominator there. Sorry, one other point about that. When you're considering also things like COVID, where we saw it really changed how people utilize the healthcare system for a significant amount of time. I think also using visits as the denominator helps control for some of that, where there were significant changes in how people were accessing healthcare. So that's part of why we use those rates. But that's why I think both reporting the absolute numbers, like the counts, and the rates can be really helpful, just to give both perspectives.
So I don't want to be the Debbie Downer here because I'm loving this conversation, but we are at our time. So if people want to stay on and discuss, but to be respectful of everybody's time, we do understand if folks need to leave. But yeah, I'm just loving the discussion though, so I didn't want to interrupt it, but I'm the timekeeper. Look, it's my gift.
I think then if back to your comment, Haley, if we can simply say that the population size hasn't changed, that's a simple thing that can go throughout the whole thing. There's something else you said that triggered. I'll try and think of it again, but yeah.
It may be worth a small comment in the beginning of the report saying exactly what Haley said about how COVID vastly impacted healthcare utilization at the same time as commercial legalization occurred. And so that is probably impacting all of the data everywhere for everything. And I think it probably applies to everything.
You're absolutely right. And the other thing I was thinking of was, as we think about how we address the report and how we interpret the information, we need to think about how those who are pro and con may think about it also, so that we, some people may say, oh, there was no difference, isn't that great, we're doing fine. And others may say, oh, look at that difference, it's huge, and isn't this terrible? And we ought to be able to address in some form either what our viewpoint on that is, or we ought to keep it blank in a sense and let the public and the legislators interpret it the way they want to separately. But if we have a strong viewpoint, then let's express our viewpoint of the committee.
With that in mind, this is Eileen with the two comments that we just heard. I feel like this is such a rich conversation. I know some people will probably have to leave. I probably will have to leave in moments. I think we'll also try to remember that this also isn't going to be in a peer-reviewed journal. It has to have data integrity. Always has to have data integrity, and that we will know that there is statistical numeracy, and most people are not going to read the report, although we want to make that anybody who looks at it takes away from it what they need to know to act in the best way that is consistent with the health of New Mexicans, and that falls within the statute. So I think that, so I know that we're going to have more of an iterative process here, but I'll ask us to try to remember that it's so hard because we're all so diligent, but it's so hard to not get so far into the numbers because we also speak in terms of numbers, but persuasion generally isn't about numbers and about facts, right? It's about how the things are, what is their frame and what is their story. So maybe I'll pause there. Team, I know that in the spirit of what Andrea had just said also too about having to go, I'm going to ask if maybe I can ask your grace if we can have a show of hands for people who are able to stay on the call versus if people feel like that maybe we need to segue into scheduling our next call and knowing that we're going to come back to this on our next call as well. Maybe a show of hands if you feel like you can continue on the call. Oh, great. So 1, 2, 3, 4. Okay, so I see 4 wonderful committee members who can, and I don't see that the staff are generally able to. So we might have to then take our egress. Am I understanding that correctly? I'll ask Gary. Did I see that correctly?
You're muted.
I think that it might, I mean, we definitely can stay on. I think all our members can do that. But again, for those that might need to leave, we might want to get at least a couple dates out real quick. And so then they could drop off but still have that. Because again, I think you mentioned you might need to drop off, Eileen, or?
I do, yeah.
Should we consider, given that our report requirements are increasing from a timeline, doing something in a month rather than waiting as long as we usually do, or even sooner if necessary? I mean, the individual committees will need to be reviewing their own reports, obviously, before that, so.
You're looking at the schedule of, tasks that need to be completed. I would say you need to meet sooner.
Oh, okay. So with that in mind, team, that maybe I'll start to put out some dates and and prospectively with a bit of an apology that I just took a new job. And so my schedule has just changed and it makes it a little bit tougher. We historically have met on the third Tuesday, of course, and the third Tuesday for us would put us on the 16th, and that on the, forgive me, the 16th of July. And I will ask if maybe is there any chance we can consider that afternoon instead? And if we can't, that's okay. So maybe I'll throw out there and just say, yeah. Okay, I heard one yes.
Early afternoon is fine for me,
Okay.
not late, not
See,
later.
I am seeing thumbs ups
Okay.
from folks.
Okay, how about 1 o'clock on the 16th? Okay.
I see a lot of thumbs up. Yep.
Okay, me too. Thank you. Oh yeah, nobody can see mine. Oh my goodness. Yeah, and I should just lower my wristbands. That's really funny. Yeah. Okay. So that we will be on the 16th at 1 o'clock, and I think we'll go from there. I apologize. I have to go right now. I support Gary. If you think that that the call can go on, I'll just look forward to sort of hearing how things go, and maybe we'll, Eleni, if it's okay, I'll circle back with you for additional follow-up. Is that okay?
And we are recording the meeting, so anything that you miss, Eileen, you can always watch at a later time frame.
Okay, thank you. Okay, I appreciate all of you. Take care, stay safe. I hope that also that you and yours who are in Ruidoso and in that area are also that they are safe. Thank you.
Thank you.
Thanks, Eileen.
Something else for folks to, we just had our first, I've actually had 3 now, reports with questions because we've had minors who have ordered hot CBD product from out of state. That they, it was allegedly CBD, but it was, one of them was a new thing that I had heard of, and I can't remember what it was now, but it's a new derivative that they're doing of CBD products that gives a very intense psychoactive effect. And we had 2 other minors that were in possession of that same type of product, and when they tested it, it was definitely significantly over the CBD, the THC content for CBD products. So we're now having to deal with this issue of it being ordered online and brought in from out of state. So, yay.
Yeah, there was actually a new health alert this morning from CDC on, I bet it's similar to what you're talking about. They were called Diamond Shrooms brand microdosing chocolate bars.
Yeah.
I'll find the link to that one as well and put it in the chat. But that one hasn't had nearly as many cases as the other Han that I sent out. But yeah, I got it in my email this morning. Yeah.
And just going back to Eileen's comment on innumeracy, I think she's right, and most folks don't know how to read the data, but we could also think perhaps help with some help from the health education side or the communication risk side of DOH, that we can put a few little suggestions in here on what these things mean. And start to educate the public at the same time in that regard, and the legislature for that matter. Gary, would it make sense for you and Eileen and me to have a on, not necessarily a Zoom, but a phone call to talk more about the overall structure of the report sometime soon?
Yeah, I think we can do that, and we can address, the issue with the references, but also with regards to what the comms team, how the lens that they might use when approaching this, so that we can already have in place what it is that they like to, sort of have there. Yeah, I think that would be useful. I think Andrea would be also wonderful to have on that call, because she probably has insights way above mine. And so that way we could also talk about the formatting, because they do pretty phenomenal things there, but it might be nice to have, give them it piecemeal so that they're not just doing it all at once, at the end of the year, but we can talk more about that.
Okay, sounds good.
Okay. Well, I guess then, as far as next steps, I think that, that we've got a great, this first section looks amazing. I think the data is there, the numbers are there. And so, almost, I think as a segue into that phone call, Hallie, we can almost start looking at this whole section 1 and start, pulling out the pieces, editing it, and moving it on to the next step. And again, thanks Eleni and Crystal for putting that all together. And so I think that's definitely, that could be started. Hallie, Eileen's already gone, but I'll mention that to her as well. And then the next 2 groups really before the meeting would be road safety and driving while impaired, and then workplace safety. Would be 2 that we would hopefully be able to have a little round robin, much like this, just at that follow-up. And I think that's Alan and Matt, I think, are the 2 that are on that. And there's been some progress there, and we'll definitely have a meeting before too long to get things rolling on those 2 sections as well. That being said, does anybody else have any other comments or any other concerns, anything they want to share before we adjourn for July 16th? Eleni?
Do you want me to work on incorporating references back in, or do we just want to keep in mind that we're going to be formatting this with references at some point and wait until you guys kind of take a look at things?
I think just go ahead and reincorporate them in, because that way it'll set the groundwork for the other groups, so that we are consistent with how we approach each section. That's just my 2 cents. Andrea, do you have, I mean, you mentioned that they always want the references. Okay, so I would just reincorporate those, and then we can just use that as sort of our template blueprint going forward for those that are addressing the other sections.
Okay.
Related to one of my prior comments, I'm wondering if we can get a sense of what the different constituencies will be who will be reading this, and what they're looking for versus what we want to state, and also how they may use or misuse the information. So as we're writing it, we get a better sense of how we ought to be positioning some of the, not just the data, but also the recommendations.
Would you say the comms team and would they, like Aria and that, is that sort of who would have their, and maybe is that, maybe we consider having Aria come and talk, or maybe, well, I don't know, we'll think about perhaps how we can have somebody sort of share what that might look like. And Aria comes to mind, but Andrea, you might have somebody else.
No, I definitely think Aria would be a good person to get kind of an understanding of from the legislative standpoint. I can tell you that the big issues for the legislators are about controlling child access, making sure it's safe product. Those are the big ones. So like, there will be legislators that will jump on like any increase in children having to seek out medical services from ingesting, but I do feel that the idea of getting like lock boxes for people and getting more funding into the program is going to be, you know, definitely a focus, because the challenge we have is that right now we do not receive any general funds for the program. The way it works is all funding goes through the Cannabis Regulation Fund through RLD. So, and that fund, all those funds are collected from licensing fees from producers, manufacturers, retail locations, labs. So all that money that they pay for fees goes into this fund, and then that funds both the Cannabis Control Division and the Center for Medical Cannabis. There's no general funds. We don't get any of the tax revenue that is coming in from tax payments for the product. That right now that is all going basically into general fund. So it's kind of a challenge. You know, we want RLD to be properly funded so they can do the proper inspections. You know, we want us to be properly funded so we can really develop our health education and do a lot more of this education and outreach for people. And you know, potentially, I know there was a proposal a few years ago when they were originally doing rec, that they wanted to have a fund that would allow people to access to pay for medical cannabis, you know. So that was something that had been proposed several years ago. But it's kind of all over the place with legislators, people that are anti and view this as being a gateway drug are going to jump on any data that shows that there is a negative impact. And, you know, people will sometimes dismiss it as saying like, well, it's nominally, it's not a large group of people. So, you know, they all have their own agenda when it comes to our program. But I will say Aria would be the person would have the best insight into, from a legislative perspective, of what it should look like. And she's also going to know what the governor's office would like to see out of this as well.
So
And perhaps, go ahead.
Yeah, sorry, I was just going to say that's really important stuff to know what are the lobbying groups and how are they going to look at this in different ways, you know, and will the licensees take some of our suggestions like lockbox and say, well, that means our consumers are going to have to lay out more money and therefore we're opposed to that. I'm just hypothesizing here. I don't know if they would do that because I don't know. But what are the lobbying groups affiliated with this, and those who are anti because it's a gateway drug, even if they're small, how loud are they? You know, loud. It doesn't matter how big you are if you're really loud in some cases or quiet. So.
Well, I think we let the data do this talking, and we remain objective. I think we sort of stay away from getting too opinionated because those groups are going to pick out and choose what they want and make their own argument. I don't think we try to preface or try to predetermine how they might respond. I think they're going to pick and choose what they want, and I think if the data is data, it's what we present. I think that we can, you know, overthink it if we try to worry about, you know, lobbying groups and what their perception might be. I think the data, let the data do the talking.
Wait, we're in public health. We overthink everything, don't we?
We do. But the big things like, you know, if it's going to have an impact on finances for licensees or patients. I mean, those are some things we really need to identify. But most of what we're talking about, like, you know, having a small lockbox and keeping your product secure is, you know, it's not expensive. Most of them have some form that many people have it that they're already locking up. But some of the information that's going to come out from our most recent survey is one of the things we're seeing is that parents with minors in the home are continuing, like over 50% of them report using the product, which is primarily smoking, in the house. And so, like, you know, if you have children in the home, like, you know, that's something that is obviously an issue, but it doesn't cost a lot. It's not going to have a cost impact on patients or licensees to put together some education materials to make sure it gets out there, and like telling people, hey, you know, don't hotbox your kids by smoking in the car with them. You know, it's You know, it shouldn't be that hard, but unfortunately we do need to do some of that education, you know, and so it's, you know, the big things that people are looking for is what is going to be the social impact, the financial impact on those groups. But Gary's right, you know, no matter what we do, people are going to select what they want out of there to support their own opinion and argument. All we can do is present the data and say, hey, you know, we know if we do this, it's not going to cost a lot of money, but we do need to make sure that these agencies are funded properly to do what we need them to do. And with our numbers, like, you know, we're still processing over 2,000 applications a month for people that are in the program. And we knew coming in that there was going to be a decline in enrollment. It's happened in every state. Colorado dropped over 80% in their enrollment. You know, we've dropped about, I believe, about 40%, 30 to 40%. So it was anticipated, but we continue to get new people in the program. So, you know, there's an idea out there that, oh, numbers are dropping, so we don't need to worry about it. But we do, because we do know that it does impact driving, it does impact children, it does impact all of these other issues. So,
yeah, Gary, generally, and Andrea, I agree with you. We ought to let the data speak for itself.
yeah.
The thing we know, though, I've been to a couple of conferences at the National Academy of Sciences on risk communication, and the thing we know is how we communicate the data. You know, we can think that two ways of communicating it look objective, but people get different opinions from it depending on how that changes. And that's all I'm suggesting. We ought to think about that so that it's as clear as possible, as opposed to giving somebody the opportunity to use it in the wrong way. And because I'm not as familiar with the lobbying groups that have been involved with all the legislation over the last few years, it could be helpful to know, just, you know, brainstorm a little bit how it could be misused, so that we're just as clear and we avoid that misuse. I mean, you're right. They're going to use it anyway. They want to use it to support their own opinions. I mean, that's why we have confirmation bias, right? That's in any event.
And I will say that once the report is done, that's why we did allow quite a bit of time for it to go through the review processes through DOH. So, you know, it is going to go through the Secretary's office. It's going to go through our Office of Policy and Accountability, which deals with the legislature. And they are very good at picking, I'd say, like, oh, we need to change this phrasing because somebody will jump on that. So we did allow for some time for that as well.
Yeah, could we bring them in at an earlier stage though?
Yes.
You know?
We can, yeah.
Yeah, we're gonna need to, because the time that we allowed isn't sufficient for all of that. So we'll need to flow it to them once it, you know, has been reviewed by Eileen and Hallie.
Yeah, maybe do it sequentially as opposed to all at once. Yeah.
Thank you.
All right. Thank you, Hallie. Well, great. And I saw there, Haley, that you had mentioned that we're getting some 2023 numbers. I do think that we are going to have some data that's post 2021 so that we can include it. And we just, you know, that is going to be post adult market going into effect. And of course, COVID, you know, just throws such a monkey wrench in so many things. Andre and I have been looking at these articles with regards to certain entities claiming that, you know, oh, adolescent use went down, and it went down remarkably from 2021 to 2022 or 2020 to 2021. And so therefore none of, you know, having a legalized market does not impact use at all. Well, we just saw on the slide here that COVID rates were actually up, and that the decrease from 20 to 2021 is rather prevalent in a lot of data there. And so I think that again, this is a group that jumped on a bandwagon and using data, skewed data from COVID to bolster the argument that they want to argue. And so, yeah, enough of that. But I guess the 16th of July, 1 o'clock, just putting that out there again. Again, if you have any other questions for Robbie or Eden, you can email those to me and I can forward them to them if you would like. And so I don't have anything more to add. Anybody else?
Thank you, everybody.
Thank you all very much. I love the discussions.
Right. Thank you all. Have a wonderful
And
day tomorrow.
Haley, thank you so much for your help with the data. You are wonderful.
Been great. Thank you, everybody. It's been great today.
Thank you, Ellen.
Bye-bye.
Great
And
work.
again, if you have other questions about the data, just let me know. I may not be able to pull a ton of new stuff, but if there's any questions with what I've sent, let me know.
Awesome. Thank you, Haley. You're a goddess among women. So.
All right. Take care, folks.
Thank you all. Have a good day. Bye.
Bye.